cancers, we for a long time had just 5-FU for us, and then we had 3 other chemotherapy agents that I've listed here, followed by the targeted agents. We had cetuximab followed by bevacizumab and panitumumab, and now we have another targeted agent, aflibercept, and you already heard a lot about regorafenib from Dr. Basadi. We must remember that most patients with metastatic colorectal have unresectable disease at the first presentation, and therefore what we are looking in these patients is to increase their overall survival as a primary treatment goal. So if you are looking at upfront resection, that's possible in about 10%. The treatment strategy here needs to be surgery, and the treatment goal is curative. Whereas if you are looking at patients who are initially unresectable, you're trying to convert them, if they're potentially resectable, into resectable, and if they're permanently unresectable, then we have option of just systemic therapy and nothing else. And again, these patients who relapse here come into the purview of the medical oncologist for tackling them with systemic therapy. So we are looking at maximizing overall survival while maintaining the quality of life. So a little bit of summary of the first-line chemotherapy in metastatic colorectal cancer. We are now dividing colorectal cancers based on the RAS mutation or wild type, and we are also looking at BRAF. So if it is a wild type or mutant type, the basic chemotherapy remains the same, but there is some evidence today to say that in those patients of BRAF mutation, maybe more intensive chemotherapy would be of benefit. The treatment choice, we need to look at just more than being the efficacy part. We need to look at the clinical presentation, the patient characteristics, which include several of them, including comorbidities, and the patient preference, their expectations, the toxicity profile, and how we are going to look at the quality of life. So the treatment decisions should take into account the patient preference as well. So the ESMO guidelines, what it says is the treatment goals influencing is based on the treatment intensity. So if you're looking at different groups that I've shown here, primary resectable, potentially resectable, symptomatic with minimal disease, and those patients who are asymptomatic. So based on them, we decide our treatment and their goals of treatment. So for the group 1, where you're looking at potentially resectable, the treatment probably is intensive, whereas for those who are asymptomatic, where you're looking at disease control with low toxicity, the treatment needs to be of low intensity. So not all patients need high intensity treatment.